a wonderful guest who is an insider in the subject that we have in store for you this evening. It's all about healthcare. It's all about health for everybody. The government recently had an ambitious plan, and that plan is being implemented as we're talking right now. And with us here is one of the people who are integral in the implementation of that plan. And he's here to help us have an idea of exactly how this is going to work, what is expected of us as citizens, what can we expect from government, and so on and so forth. Karibu sana. You're welcome.
Thank you.
With us today is Dr. Salim Ali Hussein, who looks after public health, right? That's the Ministry of Health, your primary healthcare, rather, at the Ministry of Health. Thank you so much for joining us.
I think we really appreciate for the invitation.
Your career is quite interesting. If we may just, talk about it for a second. You have a passion in what you're doing. You're not just a practicing medical practitioner, but you're at policy level. You're at bird's eye view, so to speak, on the Kenyan healthcare system. Can you tell us what is it about healthcare that pulled you into this?
Initially, when I was very young, actually, I wanted to be a pilot.
Is that so?
Yes. One day I was going to school, still in primary school. I saw somebody who actually broke his arm, and I felt I should have been able to help in a way. Then I said I could be a flying doctor so that the pilot can help people. So it generated an interest for me that how could I help in one of the other, and especially at the community level.
The community level,
yes.
Which is where, that's really the first line of defense.
Yes.
But tell me, when you were growing up, what was the state of the Kenyan healthcare system?
Yeah, basically, I think for me, as an adult, as a young adult, we used to have, I think, a bit of a challenge getting healthcare because you needed to have funds for your parents, for the family. And as far as I could know, my father did not have a cover. Mm-hmm. So whenever we used to go to hospital or we needed any health care, it was an issue of we needed to look for funds first.
Right. Yeah. And indeed, today it's the same situation because it's a very common saying that most Kenyans are just one disease away from poverty.
Yeah, I think it is true. There's a lot of what we call out of pocket, where Mwananchi actually has to get back to his pocket, literally, to get health services. But I think that is one of the things that the current government wants to change, so that we can have a cover that is covering everybody. Unfortunately, currently, the insurance health cover in Kenya is only about 21%, and about 1% is private, and the other 20 is actually from the government, which the government is thinking of changing, especially with the recent Social Health Insurance Act that the president signed. Actually, the intention is to have more than 80% of Kenyans in the cover. We all come together, especially that word social means that we all have a part to play, right. Because we will be contributing a little amount, but this little amount, when we are many, actually it will make a lot of somewhere, and it will help us when we are in need.
Okay. Now, what you've said is one of the changes to Kenyan health policy, or even the whole landscape of the Kenyan health system, and it's part of arguably the biggest change in maybe slightly over 20 years. For those who are watching and maybe are still unfamiliar with exactly what is going to change under the new system, would you care to tell us, some of the highlights of what people can expect to be different compared to what it was before?
Yeah, I think the main two changes that the current government and the Ministry of Health is envisaging in changing in healthcare. One is to have a more of a preventive, promotive health system, so that we are not focused on curative. We are not waiting for people to be sick and then we give them services from the hospital. We want actually the more than 95% who are still healthy, who are not sick. How do we maintain their status of being healthy? Because one, it is cheaper to maintain people as their health, and it is more productive. We know economically, in terms of socially, if the people are healthy, actually the nation will be. So there'll be more focus on preventive, promotive health, and then protecting the health that you have. So there will be a lot of screening, things that people themselves can do so that they can maintain their health, things that people can do to prevent diseases, but also from the facility levels, which are these some of the things that people, services that can get, but they're more of screening, they're preventive. I think the other big second change in terms of healthcare in Kenya, it will be actually the constitutional, the legal mandate. That's why there are several legal processes, and we are glad that the president has signed several acts now, like the Primary Health Care Act, which actually is the one which will be institutionalizing the preventive promotive health, which we will be working through the primary health care. We have the facility improvement financing, which basically is looking at whatever funds, revenues that are generated by any health facility, it will go back and improve the services at that same place. I think then the big one, which is the social health insurance that the government is coming in, it is an improved version of the former National Health Insurance Fund, the NHIF. Basically, it is coming up with the three funds in one. So there'll be a public health fund, a publicly financed services, which is actually the primary health care fund. Then we'll have the social health insurance fund, which will be basically taking care of the curative services that the national health insurance used to take care. But the government also now has increased another fund on top of that, which it is, we call it the chronic illness and emergency fund. So basically what that will be doing, if somebody has depleted his other funds, the social health insurance fund, and you still need services, especially for people with chronic illness, yes, for example, diabetes, renal diseases, heart diseases. So if your fund is depleted, then the chronic and emergency funds sets in. So that you'll still have services despite that your fund has been depleted. So I think basically for me, those are the big main changes currently. The way we are doing our healthcare, we want to move from a very curative, where people just think health is gotten from the hospital. But the time people go to the hospital, you actually don't have health. You're sick. You either need to repair your health or you need now to go get back your health. Yes.
Are you a sports fan?
Yes. I love soccer and swimming.
Let me talk to you about soccer, for example. If your job is a midfielder, say an attacking midfielder, or your job is a goalkeeper, and the coach comes and tells you, we're going to play a different strategy, a different formation, 4-4-2 to something else, and it requires, of course, that kind of change will require a tactical change as well as an operational change on the field. So if we relate that to the health systems, the health personnel, are there any changes that people should expect in how they conduct their day-to-day operations in order to allow them to execute this new mindset, this new tactic of, more preventive and promotive than curative?
Yes. I think there'll be a lot of, one, mindset change. There's also be, which I might call preparation or preparatory changes. For example, in terms of the education system, the training system, it also has to focus more on a preventive promotive, unlike what it is currently.
So wait, you mean the way doctors are trained and nurses and other health practitioners, how they're trained will have to change?
Yes, basically, we just have a more urgency and importance to more of preventive promotive. It's not that they are not doing it. They're still doing it. But what we expect is that there'll be now more focus, more impotence, and also maybe more time to the same. Of course, medical school, they go through what we call community health. They go through preventive promotive. But with the focus now with preventive and promotive, we hope, and we are working with all stakeholders, including the academia, on how we can enhance that. But also the training and the planning level during the implementation. Currently, what we are doing, we're actually reorienting the people into this primary healthcare model. In Kenya, we have what we call the hub and spoke model. Hub and spoke model, basically what we are looking at is making the facilities that are there and the different levels. We have 6 different levels in Kenya. From the community level, we have that we call level 1, level 2, which is more of the dispensary, most of the facilities that are next to the community. Yeah. Then we have the health centers. They have more services. Okay. Now they give more expertise services.
That will be level 3.
That is level 3. Then we have level 4, which we call the current sub-county primary health referral facilities. Okay. So these are the hubs we are talking about, and we want them to link with the level 3, level 2, and level 1, so that they work as a team. Actually, what we are calling the primary health care network. Then this primary health care network will have a technical team that we call the multidisciplinary team, so that instead of people working in silos, they'll work together.
Yes.
So the expertise will go down. So the level 5, which is more of the referral facility, county facility, they give very specialized care. Then the level 6 is the tertiary facilities like the Kenyatta, the Moi Teaching and Referral, our spinal injury, our Mathare is also one
Those
of...
at a national level, like
and
a very big level.
Very specialized.
And it's good that you should say that, because one of the criticisms for our systems is that you find even people with common colds showing up at a national referral hospital, all of them requiring the same resources that exist there, entirely bypassing all these other levels, and sometimes for very good reason, that they're not good enough or they're too far and so on. Now, there's a concern by some people who feel that this plan might take a while to come into play fully. And that, you know, the way it's been put out has inspired a lot of confidence and a lot of hype and a lot of anticipation. And a question would emerge from such a person, and they would ask, okay, so how long shall it take, realistically speaking, before we start to feel the change in mindset and the change in approach from merely curative or priority on curative to now preventive and promotive healthcare? How long can Kenyans expect to feel the change?
One, I want to say that this new model we are bringing in, or we want now to focus on it, is actually a refocus, reloading. It's not really new. Since 1978, in Alma-Ata Declaration, where Kenya was one of the countries that committed to the same, there has been that focus on primary health care. And from 1960, after 1978, we already had, as Kenya, a primary health care strategy. But what now we are doing differently is that now we are bringing standards that we can actually show the people how do you implement this primary health care. So we are not leaving it to them to do it by default. In terms of how soon they can get or feel the changes, I can say is actually immediate. In some of the counties where we have formed what we are calling the primary healthcare networks that I've just alluded to, we find like in counties like Garissa, where we started actually in 2020, actually. That was the first county that we started. Then we went to Kisumu, and Kwale. Those are some of the first ones. Now we have almost 65 primary healthcare network. We intend to do 315 in the whole counties. We are targeting each sub-county. So in these counties that we have established the primary healthcare networks, for example, in Garissa, we know, we have heard their pictures that now the surgeries, which never used to be done in health care, in health centers, now they're being done. In Kwale, we know now, recently, there are so many people who are in the household, they have been identified with diabetes and hypertension, which they didn't know. And this is just in a matter, Kwale we started in this December. Already, there are many people that have been identified. In Kisumu, where they have started the primary healthcare networks because of this support of hubs and all that, we have even seen that they're sending commodities, medicine to far-fetched area using drones.
Oh, yeah?
Yeah, we are seeing now more of services going down. There are family physicians or doctors or health workers who used to stay and wait at the hub to wait for people who are sick, yes, for them to treat or to manage. But now we are seeing a lot of those health workers going down. For example, even doing cesarean section in the health centers, managing chronic diseases after people have been put on medicine in the lower level. So we're also reducing what you're saying, self-referral, people going to the higher tertiary level where you have maybe something which could be managed at the lower level, or it's a simple disease, but because maybe you didn't see the expertise there were no commodities,
Right.
so people used to refer themselves.
Yeah.
So now we are reducing that, and we are really feeling that in the areas that we already set the primary healthcare network. So what really we have done is not something new, but now there's more coordination. People are talking, the levels are talking. So whether you increase the commodities or human resource or not, but the little that is there, now you can use it more efficiently.
Efficiently. Yes. Now, perhaps the other question now would be, with this change, you said it's not a new change, it's
Reorientation.
a reorientation, a reloading of sorts. The Kenyan health system has suffered or gone through a lot of personnel retention problems. All across Africa, people are going to other places to seek greener pastures. It is said, they call it brain drain, or in this case, our health personnel who are very, very well trained are failing to find positions within our system. How big is retention a problem for this plan, to be effected properly?
Okay, for this plan, as we are setting, there are several things that the Ministry of Health, with the support of the government, that has been doing before actually started implementing the same. Some of the things that the Ministry of Health did, for example, is it actually assessed all the facilities in Kenya, about 15,000 health facilities, including private, public, and faith-based, just to know, one, what are the type of services that these facilities are giving. Two, to know what are the gaps in this facility, one of which you have mentioned, which is the human resource. What are the gaps? Currently in Kenya, we are at about, according to the World Health Organization standard, we are at 1.38, and actually, ideally, it should be 4.5. So we are still far from the ideal situation. But we're also assessing other things like commodities. We actually have an idea what is the average commodities availability, essential medicine and commodities in those facilities. We also know the type quality of services that they're doing because of some of the assessment we have done. So this will enable us to rectify, add, or try and solve the issues. Where we cannot, now we look at which other effective mechanism like the primary healthcare networks, so that we can use the same number of facility, human resource, but to give more services. One of the other bill, which we are glad that the president signed, was the digital health bill. This digital health bill will support us to give more services remotely. We know currently, even at the community level, where the president actually launched the 100,000 community health volunteers, they've been given a smart mobile phone. So now when they go to the household, instead of the paper-based tools they used to do, now they'll be collecting that data digitally.
Just on that point, and I'm sorry to interrupt you, how transformational is that going to be to health records and telemedicine and even the pace of treatment from diagnosis to treatment? How transformative is that going to be?
I think for me it will be very drastic, and I think it's an area that is really supporting us in planning. For one, when our community health promoters used to collect the data of using paper-based tool, it used to take around a month, because they'll go to the household, which they're given about 100, then they'll need to summarize those households that they have done. And then they used to give it to their supervisor, who we call a community health assistant or community health officer. He used to also now summarize all of them in his summary. There's a summary tool. Once he summarizes that, they used to take it to a facility, to the health record health officer, information officer, who needs now to upload it into our Kenya Health Information System. With the digital system, it goes direct.
Right.
These other levels can only see what is being done. They can check, they can validate, but it goes direct. So with the information in real time. So with the information from all the households, it's actually better on than a census. Census, it is a sample. So for us, we can actually ideally have almost the information that we need from the household, including the number of people. That will help us to know the population. It will help us to know the condition in the households. That will help us to plan in terms of medicine, in terms of prioritizing the actual diseases in those areas. It also helps us to know a condition which are not basically diseases, but which need health attention. For example, pregnancy, children who need to be immunized, and we can plan. So it is really going to be a game changer.
All right. Now, you have told us a lot about what the government is doing, what your ministry is doing, and what health workers across the country will be doing. What can we do as citizens of this country? What is our own responsibility to make sure that this dream becomes a reality?
Yeah, I think before I answer that directly, the current state, especially with the Ministry of Health, we are trying to be very inclusive. Even with the primary healthcare networks that I'm talking about, part of the management will just not be ministry people, not just government people. We will include faith-based people, our donors, people who are working with partners, the community will be part of it, and other stakeholders, even the non-health sector. For example, the Ministry of Housing, ICT, we're working with them very closely. We're working with the roads people. Accessibility physically is very important for us. The agriculture sector is very important because of nutrition and all that. Directly to your question, we really expect that the community, the individuals, that they'll actually take this, what we are taking to the house, Afya Nyumbani, to be jukumu lao, afya yao jukumu lao. Okay. Or our health, our responsibilities.
Afya yangu jukumu langu.
Yes, afya yetu jukumu letu. So that we all have a role to play. Okay. For the individuals, one and foremost, what is most important is for them to take care of their health. It is an asset. We want to equip them, want to give them basic education, to give them the capacity and to empower them so that they retain their health. One, it is very expensive for one to be sick, but two, when you're healthy, you can do your normal duties, chores well, and the nation can be more productive. But more importantly, we're thinking with these changes, especially what we're talking about, the social health insurance, we need all of us to participate. The government wants everybody to chip in, and you'll chip in according to your social economic status. Yeah, it will not be just one fit all. If the president talked about, the president talked about even from 300 shilling.
I see.
For those people who can. And those who can do more, they should do more. But what more importantly is that will only all of us benefit if all participate in contribution. We will all understand that we should take care of our health, and we'll all support each other in this, so that it's not a government thing, but it is our thing.
Our thing.
So this, jukumu letu.
All right. And on that note, Dr. Hussain, thank you so much for joining us this evening. This is a huge topic. We've only attempted to cover some of it, but I appreciate your insights tonight. And as we wind up, and this is a one-word answer, I hope looking back you can be happy or proud of what that little boy who saw the man with a broken arm is able to do today.
Very much.
Absolutely. And on that note, we wish to bid you good night. May the good Lord bless you, and may you have a wonderful few days remaining for the rest of the week ahead. Up next is VAR with the great Ahmed Bahaj, who is with me this evening. Habari gani? Umesikia kwamba afya yako jukumu lako? Ndio. Mazoezi, yeah? Dr. Hussain, it's really... Mazoezi muhimu. I couldn't have said it better myself. So do something. Move your body, exercise, get your blood pumping, and I believe that's one good step towards good health.
Yes, very important.
VAR, take it away. Good night.